Our next speaker is Dr. Sumit Monga. He's a senior neuro-ophthalmologist and pediatric and squint surgeon at Center for Sight, Delhi.
Dr. Swati and respected members of the audience. So, can you just put it on the screen? Yeah. Well, sometimes it really helps to expand your horizon. And in our case, basically what it means is to segregate the neuroophthalmic cases from the glaucomatous cases. So what I'll try to do is I'll just try to attempt some clinical scenarios which will probably help us to understand the pertinent points. So let me just present one of a case of a middle-aged male who presented with visual loss in both the eyes. So he had this asymmetric cupping, as you can see, left more than right, and the OCT shows a gross thinning of the RFNL and the ganglion cell thinning. But then this was not correlating with the glaucoma. So what we did was simply do a red-free assessment where you can see now the pallor that was not earlier, visible. Now we know that the pallor is more than cupping in this case. So we also correlated this with the visual fields, and you can see a gross advanced visual field effect somehow following the scotomas being more denser in the bitemporal quadrant, and the neuroimaging revealed the inevitable. So this gentleman had a large pituitary macroadenoma, and after the surgical removal, his fields improved. So the learning points are that we have to actually sometimes specifically rule out the dispallor by the red-free light or use an OCT correlation to really rule that out. And the red flags in this particular case was pallor more than cupping. The central vision was lost early, and there was a disparate retinal nerve fiber layer and GCC loss on OCT, and the vertical meridian. The field effects were respecting the vertical meridian. Similarly, we had another case with decent vision in both the eyes, but on the fields we had this supranasal quadrantic loss in the right eye, and the disc is also correlating. It has cupping, and then OCT, and the wedge-shaped retinal nerve fiber layer defect. So everything fits in. But when you dilate this patient well and see in a red-free light, you would notice that this patient actually had an infratemporal BRVO, which was responsible for this kind of loss, which can easily be related to you can make misdiagnosis of glaucoma if you really don't dilate well. So the learning is that you have to actually have a dilated comprehensive retinal examination before labeling it as glaucoma. And another case which I saw almost a decade ago, where a middle-aged female had progressive loss of vision in both eyes. She had in fact become one-eyed, and she had this dyspallor more than cupping in both the eyes. And she was just moving around with this CT scan saying that everything is okay in the brain. And when we just saw this lady, she had an advanced visual field defect, and luckily she was carrying a field which was done 4 years ago. And what happened to the right eye field? Obviously, the vision was so poor in the left eye, we didn't really had that. So what basically you're saying is that you have advanced field effect in the right eye, and when you actually see this, supratemporal field effect in the left eye, in the right eye, sorry. So what you can actually correlate is that probably, she can have a absolute visual field effect in one eye, and there could be a junctional scotoma in the other eye, which can be due to a prechiasmal lesion. So if you see, this is the chiasmal area. So if there is a lesion which is pressing on the junction of the optic nerve and the chiasmal area, the whole optic nerve of that side, along with the looping fibers of the von Willebrand can be get affected, and this can lead to this kind of picture which this lady had. And because these things are not picked up in the CT scan, we did an MRI, and guess what? She had a meningioma both in the brain and the optic nerve. And luckily, whatever residual vision she had in the left eye could be salvaged, after proper surgery. So, correct interpretation of the visual field effects and the correct choice of neuroimaging is must where things are not explained, although you may have a progressive optic neuropathy. So, just would highlight your attention to the next set of cases. This is a elderly gentleman with the diagnosed case of arthritic AION, and see when he heals in about 3-4 months, he actually gets a cupping, which is not unknown in arthritic AION. Another gentleman who has a cupping in the involved eye, which is much more than what he actually has in the fellow eye also. So there's no parapapillary atrophy you can see. So the absence of pallor in glaucoma cases, the neuroretinal rim being healthy, and the probably peripapillary changes probably in a glaucoma cases are one of the distinguishing factors, which can lead you more towards glaucoma. Another case who had a existing keratoconus, but he also had a hyperemic papillitis in the left eye, which led to acute decrease in vision. Notice that he had an altitudinal field effect, but on investigation we diagnosed it as a atypical MOG-related anti-optic neuritis. And when this patient healed after the appropriate treatment in about 3-4 months, this patient actually had cupping in the involved eye. And similar cupping was also pre-existing in the other eye, indicating that he had a similar process going on in the other eye. So both these cupping related changes actually happened due to the optic neuritis which this patient had. So what's happening here? Neuroophthalmic disease leading to optic disc cupping, which has been traditionally a hallmark of the glaucoma. So can the changes that have been implicated in glaucoma explain the neuroophthalmic disease cupping also? Yes, probably. The tissue atrophy of the prelamellar regions, which can occur in both the pathologies, can lead to a lot of volume loss in the optic nerve, which can again contribute to the cupping. Then we can have a backward bowing of the lamina cribrosa, which is a known fat in the glaucoma, and similar thing can happen in the retrolamellar tissue loss in the neuroophthalmic disease, especially when there is an infarction of the optic nerve, and then you have a destruction or weakening of the lamina cribrosa as such, which can occur in both the pathologies. Then presenting another case where the lady had this kind of almost an altitudinal defect and bilateral optic atrophy in both the eyes. Actually, on detailed testing, we discovered that right eye just had a pseudo dyspallor, which was not really having an OCT correlation also. It was just the left eye we had this ganglion cell loss and the inferior thinning of the retinal nerve fiber layers. And this lady actually has a documented the clinical picture almost 3 years back, 4 years back, where we had a lesser cupping, but the pallor was there in the left eye too. Now, if we just see the visual fields that this lady had, so we can classically see a supro nasal field effect in left eye nasal step, which was gradually progressing over the next 4 years. And similar thing was correlating with the inferior retinal thinning in the left eye. The retinal nerve fibers were relating. So this is classical glaucoma. But how do you explain the pallor? Now, this lady was a professional hockey player and she had suffered trauma 30 years ago. And that's what probably led to the optic traumatic outward neuropathy, and the glaucoma came later. So this was a combination, which was going on. Another lady where, we have this optic disc cupping in both the eyes, cupping more than pallor, and she had gross disparate thinning on the GCC and the RFNL, which was not really fitting in glaucoma diagnosis. But the clue came from the past family history records. The brother was an index case of Leber's hereditary optic neuropathy. Mother was a documented carrier, and all her siblings had, documented LH1 mutation. And this is what was leading to the gross GCC thinning. But when we actually saw on the visual field, she had a classical arcuate scotoma, And if we compare to the fields that she had some time back, in fact, the arcuate scotoma had actually increased, indicating that, okay, she had this LH1 related optic neuropathy, but there was a subsequent glaucoma also which was coming up in this lady. So again, a coexistence of a neuroophthalmic disease along with the glaucoma. Another case where we have classical findings of glaucoma, as Dr. Pandav just highlighted, the loss of the neuroretinal tissue, as you can see in the right eye, classical notching and asymmetric disc asymmetry. But again, the RFNL and the GCC were such grossly thinned out, and if you carefully notice, there are some clues here. The thinning is more on the nasal and temporal sides rather than on the poles, which are more commonly seen in glaucoma. So this, along with the visual fields, although the visual fields were quite correlating with what we had in the OCT, so this prompted us to actually do a neuroimaging, and we discovered that this patient actually had a compressive component from a tuberculum sella meningioma also along with glaucoma. So that was again a coexistence that we had. So apart from these, also be aware of the optic nerve pathologies, which are developmental anomalies of the optic disc. A lot of has been described before. Either this can actually, cause confusion because of the disc appearance or because of the accompanying visual field defects which may be there. To summarize, we can have the diagnostic dilemma in form of discs which are suspicious or a visual field defect. So both the structural and functional defects. So the red flags which require neuroimaging would be an early and disproportionate loss of central vision along with color vision, dyspallor more than cupping, absence of notching, presence of RAPD, acute or subacute vision loss, and particularly young patient, visual fields respecting the vertical meridians, binocular, specifically the pattern like hemianopia, rather than the nerve fiber layer defects seen in the glaucoma. Then also optic disc is common but not an exclusive hallmark of glaucoma. Glaucoma and neuroophthalmic disease can simultaneously coexist, and beware of the developmental anomalies of the optic disc which can simulate glaucoma. In the end, glaucoma is not a spot diagnosis. It's a culmination of both the historical and the clinical findings, and requires a meticulous approach. Thank you very much.
Thank you, Dr. Sumit, I think for elaborate and excellent presentation. I think next is Dr. Swati. But before Dr. Swati, I think takes the stage, just a quick question basically. There are a lot of neuro-ophthalmological conditions, they can be confused with glaucoma. Now the patient is coming to you, I mean, you don't have, she doesn't have all of these investigations done. So the question is, I mean, when do you clinically, would refer a patient to a neurological or neuro-ophthalmic evaluation? Because these patients are coming to as glaucoma patient. Now you see something in the clinical examination, and then you'll say that, okay, this patient needs neurological opinion. I think to my mind, that would be a very important question to be asked and answered. So what are the clues basically that you take, for that? Yeah.
Thank you, sir. As I just mentioned, basically, we have some clinical parameters. Like, first of all, starting with, suppose the patient is a little young with no specific family history, but these are obviously, this can be blurred. There are a lot of gray zones. And the patient has a central vision loss along with color vision loss, which is happening early in the course of disease. It can occur in glaucoma also, but these are, late onset parameters. And apart from that, we do have disparate imaging, imaging parameters on OCT or visual field loss, which is respecting the vertical meridian rather than the horizontal meridian. So basically, a combination of a good clinical examination along with a good history, and always listen to the patient whether it was an acute loss or a chronic loss. Glaucoma is a slow disease, so all these parameters which we already know. So before really trying to read the reports, I would say, first actually concentrate on the clinical aspects, what exactly has happened, Is it a symmetrical? Is it a asymmetrical? You know, what kind of findings, clinical findings they have. So it's a combination of all that, which ultimately probably leads us.
Thank you.